I'm going to talk to you about a quick and brief summary of drug-resistant TB, the diagnosis and the treatment. In this video clip, I'll be discussing how one diagnoses drug-resistant TB using genotypic and phenotypic tests, how one builds an MDR regime, and the interesting thing around the InhA and KatG mutations. One of the first test results that you might receive is something like this. It's called the Gene Expert. And the Gene Expert is a PCR test which also gives you the resistance profile for rifampicin. And in this case, it is resistant. By definition, this is not yet MDR. MDR is RIF and INH resistance. So what one is looking at is actually a provisional RIF monoresistant TB patient. And what one is now hoping for is the culture result. You hope the culture is positive because that will give you further testing. The direct in this case is negative. The culture is positive, and on this culture another PCR test was done. And this PCR test in our context in Khayelitsha is called the Hain or the Lion probe assay, and it gives you more results. The RIF in this case is resistant, so confirming the original result, and the INH is resistant. So yes, this is by definition MDR, but this is still a provisional MDR case, because what one is waiting for is the phenotypic test, because this culture is now sent away for other tests where it is mixed with antibiotics to get things like the MIC. And if one looks here, amikacin, which is a proxy for kanamycin, which is the aminoglycoside, shows resistance. And Oflox, which is a proxy for moxiflox, also shows resistance. This, by definition, is actually XDR, which is why you actually need the whole resistance profile to call it what it is. We don't worry too much about the ethionamide result, and there's much debate on how to interpret it. But the most important result is the aminoglycoside and the fluoroquinolone. If these tests are susceptible, then this would be called a confirmed MDR patient. When one gets all these results, the way we build the regime presently is like this, and it might be open to future change. These are the potential TB drugs that you might have available: RIF, INH, pyrazinamide, ethambutol, cana, moxi, ethioteridazone, capreomycin, PAS, clofaz, linezolid, bedaquiline. RIF is your most important drug. In the 60s, before RIF was around, TB treatment was longer than a year. RIF came around and shortened the TB course to 6 months. When you lose rifampicin, now TB treatment is longer than a year. In most cases, we treat between 20 to 24 months on the MDR treatment. So now if you get that Gene Expert result and you have RIF resistant, these are the following drugs that you can use. So we would give INH, pyrazinamide, and we debate whether we give ethambutol or not. And the backbone of MDR treatment is cana, moxi, ethioteridazone. Now what is one waiting for is the Hain result. So one is waiting for the culture to come, which might take 2, 4, or 6 weeks, depending on the bacillary load on the sputum. So when you get that Hain result, and it shows that there's RIF resistance and INH resistance, one would continue now with the pyrazinamide, ethambutol, but one would drop the INH. And then you still go with the cana, moxi, ethioteridazone. If the phenotypic result comes back and it shows that there's resistance to the aminoglycoside or fluoroquinolone, then presently we would go below this line to the following drugs. Bedaquiline is a research drug which is showing a lot of promise, and these are other drugs that have been used extensively in drug-resistant TB. These drugs will be tailored to the kind of resistance profile the patient has. So it's difficult to discuss how these regimes would look like because one would pick and choose in keeping with the context of the clinical situation. What I want to now briefly discuss as a little bit of a side issue is the side effects. InhA classically gives you a peripheral neuropathy for which you give B6. Pyrazinamide is the most common cause of a drug-induced hepatitis and a polyarthritic gout. Ethambutol is associated with the eyes. RIF can give you anything, but it classically also gives you skin reactions. Kanamycin, you must think of ears and kidneys. That's what the aminoglycosides do. Moxiflox, the fluoroquinolone, can prolong your QT interval, so you're interested in drug interactions, and tendinitis. So in sport athletes, you can actually snap their tendons. Ethio and tiridazone both give GIT effects and can affect the thyroid. And tiridazone is known to have also psych effects. So those are all the potential side effects. Side effects for these following ones, well, I think it would be a matter of case of reading up on the drug if your patient happens to be on these drugs. Back to this drug regime that we are building. I would like to introduce you to something very interesting. In this article by the MRC in January 2012, current standard drug regimes facilitate the evolution of extensively drug-resistant tuberculosis, recommendations for improvements. They begin to discuss the concept of InhA and KatG mutations. So the question is, should we not be using the genetic information we have available to tailor our drug regimes to the kind of drug resistance profile the patient has? Let me take you back a little bit to the Hayne test. The Hayne, or the line probe assay, looks like basically like a strip with lines. And if you look at the lines, there's something called the RPOB gene, which represents 95% of the known rifampicin resistance that we know of. Whereas for the InhA resistance, KatG and InhA are the two dominant mutations that we know that represent 85% of InhA resistance. Here we have genetic information available. Shouldn't we be using it? And in that article, basically they argue the following case. That if you have a KatG mutation, what it represents is a high-level resistance to InhA. If you have InhA, which is the most interesting one, is that it gives you a low-level resistance to InhA, but it gives you cross-resistance to ethionamide. And why this is of particular interest is because when they've looked at XDR patients in the Western Cape, there seems to be a predominance of InhA. So some of the thinking is, should we not be giving high-dose InhA to patients with InhA mutations only? If one looks at a TB drug-resistant TB strain with KatG and InhA, obviously now there is a concern because there's already resistance to ethionamide, and with the KatG, now you even have resistance to the InhA. So a lot of us think of this as a precursor to XDR. Let me show you again in the regime builder. Again, if we think that in XDR patients there is a predominance of InhA, let me show you something. Let's say we have an MDR case with RIF resistance and InhA resistance, but it's only an InhA mutation. In this article, they say that with the best genetic tests available, they think 50% of PZA and 50% of ethambutol will not work in MDR cases, according to the best genetic test. Because of the InhA mutation, there's also a cross-resistance to ethionomide, remember? So how many drugs are you on? 1, 2, 3. Remember, in MDR, you can't rely on any of these first-line TB drugs. Now, before 2010, we were not actually using tiridazone, and we might have been using Oflox in 2010. So how many drugs are you on now? Effectively, you might only be on 1. So who pushed patients into XDR? Well, we did with subtherapeutic MDR regimes, which is why there's an argument for should we not be augmenting our MDR regimes or tailoring our MDR regimes with the knowledge of the InhA and KatG mutations. Hopefully in the future, with drugs like bedaquiline, we will see an improved drug-resistant TB regime which has less side effects. Fortunately, because of the genetic tools like the GeneXpert and the InhA, we are diagnosing drug-resistant TB much earlier. Drug-resistant